Good morning, everybody. Welcome. I'm Kim McGrail, and I'm Director of Research at UBC Health and a professor in the School of Population and Public Health in the Faculty of Medicine. Thanks for joining us today for our next session in the Health After 2020 Dialogue Series. Before we start, I'd like to acknowledge that the UBC Vancouver Point Grey campus is located on the traditional, ancestral, and unceded territory of Musqueam people. And the Okanagan campus is located on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. I'd also like to recognize that UBC's activities take place in community on unceded, ceded, and traditional territories of 203 First Nations and 38 Métis chartered communities, each possessing their own unique traditions and history on the land we refer to as British Columbia. Today, I'm joining you from the UBC Point Grey campus of Musqueam Nation. Before introducing our speakers, I'd like to make a few comments about UBC Health and the Health After 2020 program. So UBC Health works under the Office of the Vice President Health. We recognize the growing need for collaborations to address complex and interconnected problems facing society. We facilitate collaborations across disciplines, faculties, and campuses, as well as with health partners and communities. Our work enables us to improve the way we collectively train people, the way we develop knowledge, and how we shape policy. Our ultimate goal is to address inequities and improve the systems that foster and support health. Through our initiatives, we aim to foster an active community of health research practice and mentorship. The UBC Health Dialogue Series brings together scholars, students, and community partners to discuss important topics related to the health and well-being of society and to advance interdisciplinary knowledge translation. Our understanding of the determinants and experience of health and well-being has changed. In 2020, the COVID-19 pandemic accelerated some existing trends and put a spotlight on others, and we are now responding to the broad effects of the pandemic. We have the opportunity to learn from our collective experience and to think differently about how we define and value health, how we understand the complex systems that produce health, and how we rise to the challenge of supporting equity in health across individuals, communities, and societies. In response to this opportunity, UBC Health developed Health After 2020, a program designed to support researchers to engage in interdisciplinary collaborations and build a UBC community of health scholars. Through the development of research collaborations, academic outputs, cross-campus conversations, and open dialogue sessions, the program convenes and informs people at the inflection point of our society created by the COVID-19 pandemic. 8 interdisciplinary teams have been funded through this inaugural year to advance and disseminate their collaborative research, which includes leading a dialogue session. Today is the next session in the Health After 2020 Dialogue Series and is titled State-Level Responses to the COVID-19 Pandemic in India, Learnings from Maharashtra and Tamil Nadu. We have 4 speakers with us today, Veena, Peter, Girija, and Sarthak. And I'm going to turn it over to Veena, our colleague in the School of Population and Public Health, to start things off.
Great. Thank you so much, Kim. I'm going to go ahead and share my screen right now and let me know if you can, if these slides are coming through. Yeah. Okay, excellent. So thank you so much, Dr. McGrail, and to the Health After 2020 team, Veronica, Lubna, for the opportunity to be part of this program and to organize this discussion with you all today. Just wanted to share at the top that we would love for this to be interactive. So if you have any questions, any comments, please feel free to pop those into the chat as the session goes. And then we hope to have time for a good discussion at the end. So please keep the questions and comments coming throughout the session. So as Kim said, my name is Veena Shriram. I'm an assistant professor in global health policy here at UBC. And I'm jointly appointed between the School of Population and Public Health and the School of Public Policy and Global Affairs. So as Kim mentioned, our focus in this webinar today is around learnings from the experiences with decision-making during the COVID-19 pandemic in India. So we are now well over 2 years into this pandemic. And yet there are few in-depth explorations into decision-making and governance regarding COVID-19. And why this is important, I think we all have an intuitive sense of why that is, but just to articulate that, understanding what we're calling these upstream determinants of decision-making regarding COVID is really critical for future health emergencies, for the next pandemic, and we know that there will be one, but then also public health system strengthening more broadly. Now, why countries like India, which are federal systems such as, and similar to Canada in that regard, are important to understand is that they provide a lot of insight about subnational variation in response to the pandemic and to health emergencies more broadly. And they have a lot of learnings for us about subnational and national distribution of responsibilities. And to Kim's point, what we're hoping to do with this research project more broadly is to kind of expand the scope outside of public health, because we know through this pandemic that it really it demands an interdisciplinary way of thinking about public health systems, incorporating insights from political science, from sociology, from other disciplines. In this webinar, on India specifically, we're going to focus on two states. We're going to look at Tamil Nadu and Maharashtra. We see these as important cases because in the Indian context, which is incredibly large and diverse, these two states are typically seen as states with higher levels of state capacity. And so there are quite a few learnings that we can gather, not just for India, but for other contexts as well. Also just wanted to acknowledge that, as you'll see in this chart on the right, this pandemic in India has truly been quite devastating, particularly in the second wave. So it's really important, I think, upfront to acknowledge that there are a lot of learnings that we, I think, owe to ourselves so that we can avoid the same situation, particularly that we had with the second wave. Just wanted to give a little bit of context before I turn it over to my colleague Sarthak. The states that we're going to focus on, this is where they are geographically positioned in India. India, similar to Canada, as I said, follows a federal structure, and states have considerable authority in the context of health. Health is often seen as a state subject, is how we often refer to it in India. But obviously, in the case of a pandemic, it requires a lot of coordination with national level actors. Now, to give a little bit of context about the overall research program, these studies that we're going to be discussing today are part of a broader international effort that's led by Dr. Peter Berman, who's here with us today at SPPH and at UBC, to conduct comparative studies on COVID-19 response across jurisdictions. And this includes a case study that's happened right here in BC, but also scholars and colleagues in Georgia, the Republic of Georgia, Bangladesh, Peru, Ghana, and these two states in India. To help guide these comparisons, Dr. Berman and colleagues developed this framework, which we're calling IPOG, Institutions, Politics, Organizations, and Governance. And just to give you a quick sense of this, institutions here, we refer to the formal and informal rules and practices that are shaping human interaction in a society. So think about legislation, for example, politics, and then within that institutional framework, politics is how power is assigned and distributed. And obviously this involves political leaders, electoral systems, how issues get on the political agenda, the role of politicians versus the bureaucracy, for example. Organizations here focus on public health system agencies that are responsible for many of these key decisions, and involves the organizational arrangements and also how teams with these organizations work together or often don't work together, as we see in some public health systems. And then finally, governance is really where politics and organizations meet. It's that interface that is obviously conditioned by this wider institutional framework. And here we're specifically, when we're talking about governance, which has many definitions and is a very contested term, we're focusing specifically here on decision-making processes and how policies were implemented. So let me stop there. I think I'll hand it over now to Sarthak to take us through the first case study.
Thanks a lot, Veena. I'll be sharing my screen, and please let me know if all of you are able to see the screen. Thanks. So very good morning and very good evening to all of you, depending on where you are. It's wonderful to have that introduction that Dr. Kim had and the follow-up that Veena had in summarizing the importance of the IPOG framework in trying to understand the state response to COVID-19 pandemic. In this context, I'd be talking about research over the past year in the Western Indian state of Maharashtra. So there's a larger team that has been working on this project for the past year at international scholarships in terms of the collaborations that we've had have been very valuable, particularly the UBC team. And I'd like to thank everybody for that collaboration. So at the IIT Bombay, this is my colleagues, Satish Agnihotri, Subodh Wagle, Sujata Sonik, Khushbu, Arpit, and Himali have been working on this very diligently. In the context of the outline of today's talk, I'll be giving a background of Maharashtra and the record of this state in terms of the pandemic, as well as what has happened over the past 3 waves of the pandemic. I'll briefly talk about the study design and then focus on the key findings, wherein I'll be talking about the IPOG factors, institutional convergence, how the institutions have shaped up, and to what extent they were important in shaping the response of the state. The political factors, as Veena talked about, the organizational insights, and lastly, governance. I'll conclude with some insights from the study, as well as briefly discuss the policy implications. So Maharashtra is the Western Indian state that Veena showed in the map. It's the second most populous state. In terms of population, it is bigger than Egypt, somewhere close to Ethiopia. And globally, in terms of a subnational district, it is still the second largest in terms of population. In the COVID-19 context, the caseload was the highest in the country, around 8 million. And in terms of deaths also, it has been at the top, around 150,000 as of today, as per the government statistics. The second wave in particular, in the summer of 2021, was catastrophic. There are a lot of lives that were lost that I talked about earlier. Much of it happened in the second wave. And there was a third wave much later, which in fact, in terms of the peak and its amplitude, was much higher than the first wave, but lower than the second wave. So why Maharashtra is important in the context of a study, a jurisdictional case, to understand the COVID response is largely also because of these 4 factors that our team considers important, is that relatively its performance has been better despite the size and the complexities and the other challenges that the state offers in the context of federalism in India. The state experienced fewer court strictures in terms of the restrictions that were experienced in terms of the orders that came up compared to the other states. It had a few count. In terms of the performance of the state, particularly certain districts and the Mumbai metropolitan region in particular, and the municipal corporation therein, the Brihan Mumbai Municipal Corporation was particularly lauded by both national and international media, given the challenges how they managed the COVID despite the uncertainties that were posed. There were no reports of prolonged shortage of medical oxygen, unlike in other states of India. There was also no mismanagement of crematory or cremation facilities, unlike in several other parts of India. Now, coming to this IPOG study in Maharashtra, this study that started in the fall of 2021 was funded by the World Bank Country Office in New Delhi. The objective has been to understand the decision-making, the upstream factors within the IPOG context, in terms of how the IPOG framework offers us insights in understanding how decision-making happen upstream. And it also helps us understand these contextual factors better. And Veena has nicely summarized the framework. This is a qualitative research where the focus was on 4 districts within the state. These 4 districts in themselves could be considered as some small nations. In fact, if you take Mumbai out, the other 3 are also very interesting in terms of the characteristics. One of them is far from Mumbai, Amravati, which is also considered the starting point of the Omicron variant, I think second round. Satara is relatively closer to Mumbai, but offers very interesting variations in terms of how the local administration had managed the pandemic. And the second state, or the second site in this context, which is KDMC, is closer to Mumbai. It's the Kalyan Dombivli Municipal Corporation. So one objective of our study was also trying to understand to what extent even the downstream factors could be understood as we conduct our study. Though the focus has been on upstream factors, we also realize that it's important to understand the perspectives of the frontline workers, the medical officers, and those who have actually been the warriors in the COVID context. Though our key informants in the upstream context have been district collectors, these are executives at the district level, which is a sub-state administrative unit in India, the chief executive officers, the commissioners, the disaster management authorities. So there's a panoply of different structures in place. I'll briefly talk about why that is important given the organizational aspects of IPOG. And we emphasized in having semi-structured in-depth interviews and focus group discussions. We also reviewed government orders and the emerging literature on COVID-19. So in terms of the broader timeline, just to understand that it's a federal structure, so there are a lot of measures that are undertaken by the state, as in the state government, as well as the center. So on this graph, so anything that is in blue color, those are the actions of the state, and anything that is in orange are actions of the center, the government of India. One important aspect of this timeline broadly of the first and the second wave since March 2020 to July 2020, and then from August 2020 to April 2021, that's when the second wave had its peak. One needs to understand that the state had already invoked the Epidemic Act to a certain extent, though right on the next day, the center invoked it across all the states. The imposition of Section 144 and the lockdown that in fact preceded the imposition of the nationwide lockdown on the 14th of April 2020 by the government of India. And as you go down further in terms of the timeline, several regulations came in, mostly by the state government, in terms of the containment measures, in terms of the relaxations of the lockdowns in several phases. And many times, even if the central government had decided a deadline for the lockdown to be lifted, or what is known as the unlocking, the state government went ahead and extended it as if it was exercising its agency of some sorts. As we started deciding that, okay, it's already January 2021, perhaps the worst is over. And that's precisely when there was a political statement by the premier of the country in the sense that we have won over this virus. And this is also around the time before the second wave had its devastating effects, there were concerns of complacency in the upstream. So one aspect that was also important is at the same time, there were a lot of efforts being put in to try to understand to what extent the vaccination and the public health system capacity could be beefed up to really prepare for an impending second wave. But as the second wave struck and the lockdowns also continued, by that time, the vaccination of the frontline and the health workers had begun. So the vaccination achievements of the country has been extraordinary in terms of the size and the scale that we have been talking about, and in terms of the uncertainty that was there, in terms of the efficacy and the other scientific aspects. So this is a broader timeline, just to give you a perspective of how the state and the center had been going ahead with their measures to contain in the broader response to COVID. Here's a sneak into the organizational structure. It's the organogram of the Department of Health in Maharashtra. So at the top, we have the Indian Council of Medical Research, ICMR, and the Ministry of Health and Family Welfare, which is giving the guidelines to the states. We also have the Ministry of Home Affairs of the Government of India. So this is top down in terms of what the state governments across the country should do. What are the different guidelines? So the state task force are already in place. Now, if you come further down, you see there the district officials within a state. So within Maharashtra, we have these districts, and each district will have its Zilla Parishad, CEO, Chief Executive Officer, the collector, the district magistrate, and this is a larger structure that is across the state. So within that, there are two branches, as you see. To the left, we have the district health officer, the sub-district health officer, the taluka health officer. We have a deputy district health officer, then the health system, the medical officer, the hospital doctors, the multi-purpose workers. And to the right of the sub-branch there, you'll see the ASHA supervisors, the accredited health workers, the ASHA workers are there. And at the other branch, we have the district civil surgeon, the medical superintendent, the duty doctors and nurses. And these are all stakeholders we interacted with during our study as well. So what this organigram suggests is that even though there are guidelines being issued by the central government, the execution is largely boiling down to how these stakeholders and the bureaucrats and the doctors and the superintendents across the districts are really, in a way, following that print or that order that is often also passed on in a WhatsApp on a day-to-day basis as the pandemic caught on. Now, in terms of the emphasis on the institutions, we need to understand that India has a colonial time Epidemic Diseases Act 1897 that was in a way brought into place to contain the effects of the bubonic plague. And Pune in Maharashtra, which is around 180 kilometers from Mumbai, was where this response was necessitated. The center advised the states at the start of the first wave to invoke this act. And there are a lot of aspects of constitutionality that has been discussed in the literature of late. And the center also invoked the National Disaster Management Act 2005, as a result of which you can label the COVID pandemic as a national disaster. So that gives the state, the center, such an extraordinary rights and such an extraordinary teeth to really handle this pandemic. These restrictions that mostly came about in the timeline were because of the invocation of these acts. So the Ministry of Home Affairs at the center played a very important role relative to the Ministry of Health and Family Welfare, because we're largely talking about regulations, or talking about street level containment. We're talking about greater importance of the police force and the state machinery to make sure that there is compliance. There are restrictions on movements, mobility between district and state boundaries. There are lockdowns and containment orders, which is under the purview of the Ministry of Health Affairs. And the health and travel advisories that you might have read or seen or maybe experienced at some stage was due to the Ministry of Health and Family Welfare. Though the Ministry of Health and Family Welfare was also delegated certain tasks by the Ministry of Home Affairs. ICMR, or the Indian Council of Medical Research, was key technical resource for COVID-19. The ICMR officials were pretty much faces that people across the country watched on the television screens or the smartphone screens over that period of uncertainty. But at the same time, during the first wave, there was substantial confusion about the protocols for testing, screening, for medications, the broader healthcare prescriptions, and so on. There was convergence among the several agencies upstream, but to our understanding, it was ad hoc. And there were several coordination issues that came up during the course of our research. We found that there were several other institutions in the nation, particularly at the central level or the centrally funded institutions that had expertise in immunology or virology or epidemiology and so on. But that expertise, to our understanding, was not really sought out to the extent it should have been. So to a certain extent, there were concerns about whether there was a scientific basis for much of the decisions that were being taken during the timeline we discussed. And I also talked briefly about how in early 2021, there was a premature announcement of victory over the virus, and that created concerns about compliances. And remember, this is around the time the state is also pulling up its socks to be in action and to prove its point, largely because of the importance of the institutions in the state, despite the limitations of the public health system or the health systems in particular, and the constraints of politics. So this is why the Maharashtra case becomes particularly interesting, as we see now that this is around the time when a new government had come to power at the state, and they had been allies to the party in power, but right around that time, they had drifted apart because of political differences. And this is also giving a lot of interesting intersectionality to understanding how politics in the background as well as the foreground was essential to our understanding of how these institutions and the governance really intersected with politics. What we understood largely, in fact, this is one of the most important findings of our study, is that over the 3 waves, over these 2.5 years that we now also refer to, there was an evolution of the center-state relationship. So that dynamics is of particular interest. We saw that as we moved from the first wave to the second wave and the third wave, there was an increasingly decentralized response to the pandemic. It's as if at the early stage, the central government was having a harder stance. It was pretty hardlining also in terms of its rebukes to the state for at times maybe doing more than the center. But this is also where these deviations started being tolerated more and more by the center or the government of India. And this is what we label as the gradual softening of the center compared to the high-handedness in the earlier stages. Now, these strained center-state relationship had implications on the fiscal aspects of managing the pandemic in terms of the facilities for equipment or the medical facilities, the supplies and the vaccine distribution in particular. But that did not, fortunately, that did not really affect the citizens to the extent that one would have anticipated in the early stages. Because as the softening is taking place, softening of the center is taking place, there are certain softer bargainings or certain understanding that is emerging that, well, we will have our say in something which is important symbolically as well as for the central guidelines, but we'll also have it your way to as far as the aspects that are constitutionally valid. And I'd be happy to elaborate on these aspects as we go forward. So to summarize the politics aspect of IPOG in Maharashtra, we realize that there are very interesting facets of competitive federalism. That means the center-state relationship and the dynamics therein versus the cooperative federalism, the state and the district kind of dynamics, the relationship between the state and the district administration. What sort of protection is the state government providing the district administration against the influence of the center? So that appeared very important in our study. Local political manifestations were also very interesting. We saw that particularly around the bordering districts within a state, as well as between 2 states, there was some sort of political scoring or kind of one-upmanship happening. So in this context, we see that there were also issues of politically connected patients, particularly when the peaks were happening. So there will be some local actors who will try to claim political affiliation and seek some sort of benefits given the health system, which was already overloaded during the peak. And there were a lot of variations in the district level cooperation dynamics between this center and the state, as well as among the actors within a district and sub-district level, particularly the village, the panchayati raj, or the local self-governance that we have in the Indian system, and the representatives at the district or the Zilla Parishad. So broadly, we see there are multiple layers of politics that is playing out here. Now, coming on to governance, we realized that the governance structure was important in determining the nature of the COVID response. Particularly, there was a change in leadership in the BMC, or the Municipal Corporation of the Greater Bombay Municipal Corporation, which is responsible for action in the broader MMR region. And that leadership change has been lauded by several sections. Multidimensional constraints also affected the way this governance played out. And these dimensions are far in terms of the kind of downstream insights that we realized are important to throw light on this multidimensional constraints. The civic bodies interestingly competed with each other to set up these jumbo centers. These are massive facilities with maybe 15,000 beds or 12,000 bed facilities at high cost, and many of them were underutilized. So this is what we consider as an isomorphic mimicry in Andrews et al. Context, is as if it's in a more conventional wisdom would suggest that there could be a fear of missing out, but you want to prove your point that by mimicking something which has been considered successful, perhaps you are scoring a point in that context. But there were concerns raised whether these decisions to set up this jumbo facilities, for instance, were guided by scientific consideration, or they were just an example of action bias on part of the actors. There were several instances of unutilized capacity in both the staffing in the health system perspective as well as the physical infrastructure many contexts. A very interesting insight came in terms of the role of the private sector and how in many times we see that the public sector and the private sector are hands and gloves without any codification. So that was perhaps because of the pandemic or the exigencies or contingencies of the pandemic, that was in a way legitimized, that some private players could get that bandwidth to have some undertaking in terms of a business arrangement in the context of the pandemic response. There are many examples that we come across. And more importantly, to the extent that surveillance was legitimized in the time of the pandemic, in the garb of governance, is also a concern that has emerged from our interactions with the frontline workers and other district level workers. Now, to broadly summarize the set of learnings that we've had across institutions, politics, organization, and governance, we believe that the institutions in Maharashtra demonstrated a strength that was also inclusive, and several organizations were involved. There were different task forces that were put in place. And to a certain extent, if you compare the center and the state, there were indeed variations in terms of how they dealt with in terms of the institutional realities influencing their actions. The use of the archaic laws, particularly managing the pandemic, and the role of the politics to a certain extent is in a way intersecting with it. The tussle between the central government and the state government to a large extent has shaped the contours of this dynamics. We believe that there has been a softening of the center in terms of the dynamics across the waves, wherein discretion has been given to the states to design the strategies of response. In terms of the organizational structure and the abilities and the capacity of the health system and the bureaucracy, the legislature, the executives, we largely see that the executive order is what has influenced the pandemic response. The Ministry of Home Affairs took on an important role relative to the Ministry of Health and Family Welfare, and the role of the public-private partnerships in terms of non-codified interdependence also leads into the governance aspects, wherein there was a legitimization of increased surveillance in the backdrop of the measures to contain and to regulate and so on. And there was an increasing decentralization in these responses. We are also looking into aspects of accountability because of the prolonged lockdown and the lack of scientific merit in many of these decisions. And in terms of the way the vaccination drives are being considered as a success, despite the limitations, we're trying to link some of these factors. And finally, the several policy implications, though this is an important study that will help in mainstreaming the IPOG framework to analyze the upstream and the contextual determinants, particularly in pandemic response. And I believe the health after 2022 settings, this is going to set some examples for us to follow. There are very interesting comparative insights that we look forward to, not from just the Indian context as we see in Tamil Nadu today, but also in other state and other jurisdictional contexts internationally. And the most important insight that we really gathered from our study so far has been that despite the institutional strengths, no matter what the degree we're talking about, the political polarization impacts the pandemic response. And this is also having an interesting dynamics that this qualitative research has enabled us to understand. And this is also happening in the broader context of federalism and COVID-19 response in the country. So thank you so much for your patient hearing. Be happy to take on questions later. Thank you.
Excellent. Thank you so much, Satak. So we are going to now move into the Tamil Nadu presentation. So I'm just going to share my slides and let me know if you're able to see these. Yeah. It's coming through? Okay, great. So thank you so much, Sarthak, for that really excellent presentation. A lot of interesting insights there and a lot of interesting scope for comparison, I think, going forward. So now we're going to discuss findings, as I said, from the state of Tamil Nadu. And I'm doing this together jointly with my colleague, Dr. Girija Vaidyanathan from the Indian Institute of Technology in Chennai, India. And Dr. Vaidyanathan has also had a very long career and a very impressive career in the civil service in India, retiring as Chief Secretary of the state of Tamil Nadu of a couple of years ago. So she has a lot of experience in the issues that we're going to talk about today. But I want to acknowledge our colleagues at IIT Madras and here at UBC at the School of Public Policy and Global Affairs, Shambho Basu Thakur, Sabah Haq, and Hari Narayanan for their efforts in this project. We also want to acknowledge Health After 2020 funding in helping us conduct this study. These findings that we're going to present today are very much in their early stages. So we are still in a process of, we've completed our data collection, but we're very much in the process of pulling the story together. So we're not quite as far along as our colleagues in Maharashtra, but we saw this as an opportunity to share some preliminary findings and give you a sense of what we're learning and gather your feedback also on the direction that we're taking. So in terms of why we decided to look at Tamil Nadu, so Tamil Nadu in India is often considered a strong performer in the federal context when it comes to economic, health, social, and other indicators. And actually, this is not just in India. I think the experience of Tamil Nadu has been written about as a global example of good public health practices. There have been a series of natural disasters and outbreaks that have taken place in the state that have also engendered some institutional learning about how to deal with these kinds of crises. But there are some differentiating factors in the Tamil Nadu response, and particularly the fact that there was an election that took place during the second wave, and that, as Sarthak mentioned, the political dynamics between the state and the center, those evolved over the course of the pandemic. And so I think it generally provides could provide some very interesting insights. In terms of the methodology that we used, similar to Maharashtra, it was entirely qualitative. We did an extensive document review, media analysis, and then in-depth interviews, primarily with government officials, civil society, and media at the state level, with some interviews at the district level in terms of individuals running the response, but we didn't go as further into the hierarchy as our colleagues in Maharashtra did. So this is very much going to focus on state level and also to some extent state and district level factors. So we're moving on now to provide an overall summary of the pandemic in Tamil Nadu between 2020 and 2021. And we're primarily covering the first two waves. In this presentation, we're going to be looking at upstream factors as they pertain to three distinct time periods. The first is this period from the early part of 2020 up until probably July or August of 2021, which we're considering this first wave period. And then we're going to look at this period between the waves, which is when the election took place, right up until the start of the second wave, which overlaps with that election period. So some key policy milestones to note here is, and this will, I don't want to repeat much of what Sarthak has mentioned has happened in Maharashtra, because there is obviously a lot of overlap in the national context. But what I will mention is that the policy response really started to kick into high gear in the second week of March of 2020, after the central government had its high-level meeting. The chief minister had the first meeting on COVID. And then following that, you saw the series of actions with what was called the Janata curfew, which was a nationwide lockdown, which was meant to sort of mimic what was going to happen later with the longer lockdown. But the longer lockdown also happened, the state actually implemented it one day before the national lockdown began. So some similarities between these contexts and taking action before the center had issued their orders. But you do see in this period that there was tremendous activity taking place in this early period. Even though the case counts were quite low, there was a lot of activity to kind of keep in terms of keeping transmission down. Two key events that happened in the state at this point in time. There was an outbreak that was taking place in one of the largest markets in Asia, the Coimbatore market, which really brought a lot of, it sort of accelerated activity at the state level. And also the return of individuals who had taken part in a religious pilgrimage that, again, also generated activity within the government to start taking action. Following this, there was then a period of some change in the bureaucracy. The health secretary transferred. And then we entered this period of relative stability between the first wave and then the second wave. And then when we look now into 2021, we start to see that you can immediately see, just looking at the policy timelines, that there are far fewer decisions being taken in the lead up to what was an unbelievably large spike in cases and deaths during the second wave. And at this point, a new government was sworn in late April, early May 2021, which was a party that was in opposition to the central government. I just wanted to, so this is just to provide an overall context, and then we will go into some of these in more detail. But just to say that this index that you see over here is an initiative. It's called the Oxford Stringency Index, and it's an initiative by the Oxford Coronavirus Government Response Tracker. It's meant to be a composite measure of 9 different metrics regarding the COVID response. And so you can see here just the nationwide, this was one of the most sort of severe measures taken globally. But then even though we had a far more drastic crisis in terms of transmissions and deaths in the second wave, at the state level, and presumably this would be true nationally as well, far fewer measures taking place in 2021. Okay, now to move into the institutional context, Sarthak has mentioned the fact that the central government requested the states invoke the Epidemic Diseases Act and also the Disaster Management Act. But Tamil Nadu, interestingly, is one of the first states in the country to have its own Public Health Act, which gives considerable powers to public health officials to take actions on various aspects of public health. So in the context of epidemics and pandemics, to appoint more staff, to take more prevention measures, ensure compliance with the private sector. And it was also actually used for mandatory vaccinations as well, which kind of brings up some questions about where does the national legislation end and where does the state legislation begin, and what's the overlap there, and what are the gaps? Tamil Nadu also has a long-standing public health cadre, and one of the first, and it was the first and probably still one of the few in the country, and this perception of high state capacity. And what our respondents were telling us was that there were the learnings from previous outbreaks, the tsunami, dengue, H1N1, and other crises that have happened, the floods that happened in Chennai. All of these have created a lot of institutional knowledge that resulted in some structural change, but a lot of it was institutional knowledge that the individual bureaucrats took with them into different crises. As one respondent said, one of the learnings was we just have to act. This idea that you just have to address the problem head on immediately. And also that this disease is bigger than any one department. Institutional memory tended to be stronger at the state level and less so at the district level. So that's also another gap that we saw from our respondents. I'm going to turn it over now to Dr. Girija to take us through the next few slides.
Good evening, good morning, everybody, as the case may be. And this is just a small opportunity for me to present a few of the slides. I must say that we've all worked together on this. And as Veena said, we're still in the preliminary stages of trying to understand what happened or what didn't happen. but we're very glad to share it with you so that your insights will also help us refine our analysis further. So I'm talking about the organizations that were there. And as all of you are aware, and if not even in the IPOG framework, it's organizations that define how a system reacts. Now, what we have presented here is pre-COVID. How does the Tamil Nadu state react to emergencies? This was not public health emergencies alone, but all emergencies. But we have worked in all the departments to try and show you how things would work out. And as Sarthak had shown, there is the cabinet, the chief minister, the health minister, and various other ministers. And we had the National Disaster Management Act was discussed. The National Disaster Management Act in our state and in many states is implemented through an independent department called the Revenue Department. The name is misleading. This was because at the initial stages, this was the department that collected land revenue. But ultimately, it became much more than just a revenue collecting department. So this particular department was where the principal organization for managing disasters existed through the revenue secretary, but more so through a position called the Commissioner Revenue Administration. And he's the one who headed or who ran the State Disaster Management Agency. The chief secretary, who is a coordinating official for all the, which is the post I held before I retired, is the person who coordinates across all the departments. But in our pre-COVID time frame, the chief secretary's role was largely that, just coordination. The health department remained a reasonably independent entity. In our state, the health department looks after the rural health and small municipalities, whereas the municipal corporations, that is the larger municipal structures, come under an independent department called the Local Administration Department. So this is how it existed. And at that time, the smaller epidemics that we managed, the dengue, the H1N1, were all managed by a small control room in the DPH. The DPH is our Directorate of Public Health. This is the public health establishment that we had. We always had a small control room there, but it was just that, a very small control room. So I just wanted to present this to you. And on the side, you can see the boxes showing the technical agencies that were there. And you can also see that at the district level, there is the district collector, which remained for all kinds of emergencies, the head of the district. Can you go to the next slide, please? Now, with this structure, this is where we start. And around January, February, as internationally everyone starts talking about it, there are state level public health officials who start asking for some preventive action. But that is just that. They're just voices to be heard. And it takes nearly a month for these voices to come together, because this is what they've said. There was a debate about the severity of the problem. The naysayers said that these people were reacting too fast. So while the public health department was making its noises and went on record many times, the general decision-making authority, which was the chief secretary, actually got into play only in late March. Now, late March is the same time, as you've seen, where the central government also comes into play with its guidelines, with its Janta curfew. And around the same time, it's the same time when we started seeing what was the effect of people who had traveled on a religious pilgrimage and had come back. We claimed at that stage, the state kept claiming, and most of our respondents have told us so, they said it was an imported problem, that only there was a very mild smattering of cases due to people who had traveled. But only after late March and early April, everyone realized that it was not just something that could be wished away. And Tamil Nadu, I think in early statements, some of the political leaders talked about the fact that Tamil Nadu is lucky enough to have escaped, etc., as early as April. Then by early April, we realized that we had to step in there. And in the meanwhile, you had talked, I think we've all talked about the fact that Tamil Nadu was already well prepared with other emergencies, even health emergencies. With the help of CDC Atlanta, as well as the national CDC, we had set up a state public health emergency operations center. We had set it up, we had started setting it up, but it was accelerated and brought into operation for the first time. I told you earlier that we had a DPH control room, which is a very tiny structure reporting to the Director of Public Health. Now the State Operations Center, as I'll call it, SEOC, as I'll call it for short, it comes into play. Not only does it come into play, we bring in officers both formally and informally into that structure, because we do not have that many officers. One of the officers from the health department is brought in to head it, but additionally, we bring in many others. What Veena called as institutional knowledge. People who were earlier handling various types of crises and had expertise were brought into the SEOC to lead the response. So this is quite unique to Tamil Nadu. We don't know whether we have seen it in other states. They were brought in. Most of the time, they kept holding their other responsibilities as well. And we also brought in all the agencies that we felt were required at that time. It was still a very early time. We did not know what all we had to do, but we set up various groups to look at, infrastructure management, various things that we thought were required. And these were all brought under the State Emergency Operations Center, which reported to the Health Secretary. It was literally brought under the Health Secretary, and the Health Secretary was brought front and center into the emergency response. Now, in addition to this, since at this time, you realize the health department is handling only the rural health, and urban health is a big issue, especially if you take Chennai Corporation like Mumbai. Much of the early problems started in Chennai Corporation. So we bring in what we call monitoring officers or nodal officers. This again is something we learned during the floods and during our other crises. So what we do is we bring in officers who either worked there before or who have expertise in the subject, and they came to help and handhold those officers who are actually holding these posts. Now, it's a big debate whether this is a help or a hindrance, but there has been both sides to it. And by and large, it seems that for many people, the nodal officers played a critical role, especially as eyes and ears of the state government, to bring back information to see what we should do. And many of the experiments that succeeded were done with the blessings and with the cooperation of these nodal officers also, who are much more senior to those who are actually holding those charges. And at this time itself, early time, even as we formed the committees, the technical expert committees, which we will show you in the next slide, we started involving the National Institute of Epidemiology at Chennai and CMC Vellore in various capacities as individuals. But by early April, we set up 3 or 4 expert committees, each one for a purpose. Some of them were issued by government orders. So again, a lot of work here. You can just see, I don't want to spend too much time on this. You will see this. I will be explaining a bit more on what happened to the Chief Secretary here, but you can see here that the Emergency Operating Center now becomes the critical coordinating place. The nodal officers have come in, and the National Health Mission actually becomes the agency for both information flow and funds flow. This is what we found, that at this time, that is the role they played. The district collectors still remain critical. The Chief Secretary starts playing a really important role. 2 or 3 expert committees, 2 expert committees have been mentioned here. There were various expert groups set up, but these 2 were the most important. And they also started advising the Chief Minister directly, and to a large extent, the Chief Secretary. Go to the next slide. You can see that one major thing that happened was the Chief Secretary really became, can you go back to the previous slide? The Chief Secretary's role here, he becomes like an incident commander. He takes over the whole thing, because at this time there is coordination with the central government, there is coordination with the districts, there's coordination with the municipal bodies. So the Chief Secretary, though he had no earlier role, he did have a role, but not such a critical role in disaster management. In the COVID-19 first wave, the role of the Chief Secretary is extremely critical in managing the crisis, to the extent, and we are also quite positive about the way the state government, from our interviews and from the figures, the way the state government handled the crisis. Next slide, please. Now, this is where Veena told you about the relative stability between the end of the first wave, where we almost thought everything was done, and early 2021, the key decision makers continued. The Chief Secretary also continued. And in 2021, the elections were declared. Around 2021, the elections were declared. The manpower got diverted for election work. The collectors got their priorities changed. Then what happens here is the Chief Secretary also retired, not critical, but that also made a big difference in terms of personality. And as a result, the kinds of actions with the experts and the health department kept asking for, the non-pharmaceutical interventions that they kept asking for, did not happen. This was also the same time, before the election was over, that the central government did not really, you will see this in politics, that they really did not see their priorities also shifted. The state government was in the middle of an election, and at this time the election takes place, and they've also hit the second wave, and the new government goes into the second wave running. They give more responsibility to the health secretary and the MD NHM, who becomes the head of the war room. The war room is again a similar concept. The SEOC still continues, but Now the priority goes to the management of logistics, medical services, medical education, ambulance. It becomes more of a supply and demand situation. And though there is a lot of debate as to what is the role of the SEOC and the war room, most of those working at the district felt the presence of the war room helped them in sorting out issues at a greater speed. There were also district level war rooms set up, but these were as good or as bad as the persons who held it. Next slide. So this is just the same thing showing how it shifted. You can see that as happened in Maharashtra, delegation increases with the wave. First, it was the central government playing a main role. Then it was a very strong state government with the chief secretary. And lastly, it moves to the health department, but delegated largely to the districts, the district collectors taking the lead. Veena, can I hand over back to you?
Yeah, absolutely. And I'm also just conscious of time. I know we only have 4 minutes left in the session, and we probably have much more content than that to deliver. So what I'll do is, just in the interest of time, I will quickly, we have covered a lot of the key points that we wanted to make. What I will do, just in the interest of time, because I want to make sure we give Peter and Kim a chance to kind of give us some closing comments. Just to reiterate the points around politics and governance that we've woven through the comments. If anyone is interested in these, I'm very happy to chat with you after the fact. I did want to end on this point that, maybe end on these last two slides, that there was this sense of complacency between the waves, and that officials in terms of decision-making when it came to governance really went into crisis mode. And they underscored the intense challenge of basically trying to manage the crisis with oxygen, with beds, with generated crises such as remdesivir, which they said was something that was generated by the medical community and by patients, but not necessarily was something that is within the mandate of the health officials to procure that drug. So some very interesting, I think, reflections about how things rise to the top of the agenda during a crisis. And I think we will leave you with just a couple of quick policy implications of this study. There's clearly a need to address gaps in current legislation at the national and state level. Where do they overlap? Where are there still lacunae? We absolutely need better capacities and structures to deal with health emergencies. This includes an alert system for outbreaks that can be protected from political events like elections, so that we don't run into the situation that we ran into in Tamil Nadu going forward.
So I will also try to be very brief. I guess we're going to go 5 or 10 minutes over, but just to say that these two case studies are part of a set of case studies that we've been working with colleagues all around the world in 11 different jurisdictions, including 4 provinces in Canada and 7 sites internationally, to explore the relevance of looking at IPOG factors in decision-making in this public health emergency that the world experienced. It's clearly not possible for me to, in 2 minutes, summarize all of that work. I'm not going to try. I will just say that some of the things that come out of these case studies include that there clearly is a very important interface between politics and public health systems and organizations. It isn't clear that there's a single direction of those effects, that democratic politics is always better than less democratic politics in the actual response to the pandemic. But what is clear is that there needs to be some thinking about the role of politics and public health organizations, how they interface, and protecting some of the independence of public health organizations in those processes in the time of crisis. We also learned a lot about the different types of organizational structures. And here, this is really a relatively unexplored field where we can see in different levels of government and across different countries, different ways in which public health organizations sit within larger governmental structures and relate to local communities and other organizations. And this is clearly something that needs to be included in future discussions about strengthening capacities to respond to public health emergencies. I think one of the general consequences of this observation is that we see a tremendous amount of attention in terms of capacity building to the very technical elements of public health organization. More epidemiologists, more laboratories, more storage of PPE. All of these things are important, but our studies suggest that they are only part of what's important, and that we also need to carefully consider the structure of these organizations and the skilling of the leadership of these organizations in terms of how they interface with political structures, with civil society, with the private sector, and even how they interface with new media opportunities, including the new kinds of social media communications that were so important. These are not things that we typically see as the capacities of public health systems, but I think we need to think more carefully about those. So let me just conclude by saying we have a lot of work to do with these case studies, but our long-term goal is to learn about experiences that have worked better in managing a crisis like COVID-19 that can be translated into future crises, which will not only be acute infectious disease crises, but other population health crises, and how we can make sure there's space in the conversations about investing in strengthening public health response for thinking about the capacities to respond to these IPOG challenges. I'll stop there. Thanks very much.
Thank you so much to all of the speakers and to all of you for participating. What an amazing amount of information. It's so interesting. And I'd love to carry on the conversation as you see so many parallels to other experiences in COVID. So thank you so much for a great start to the day. And I hope a good end to the day for those of you who are elsewhere. I just want to say, I want to make sure you're aware of our next session in the dialogue series, which is going to happen on November 30th and will be head by Natasha Puri. And I'd also encourage you to sign up for the UBC Health newsletter so you can be aware of other events and opportunities. And with that, thanks again to our speakers and have a lovely rest of your day.